effective, broad therapeutic window. It's safe for human tissue and expensive, instant results. Systemic antibiotics cannot get into dead or damaged tissue. Even if antibiotics work, they take several days. With this method, you can eliminate the development of resistance because bacteria is all destroyed. And if the bacteria is resistant to antibiotics, it's not resistant to PDT. So is another article, 2015. Very interesting, this article, if you want to know more about. Since I am working with this, I did a trial, I did some publications, I did a serial of case serial, I did a court study, I did an algorithm. And you can look for it if you want. What's the process like Tardive protocol? Tardive protocol is two things, Tardive algorithm and APDT. Tardive algorithm. In 2013, I feel the necessity to classify
or 12,000 visitors per day. And for the month and for the year, that's millions, and there are only 160,000 persons. So Barbados, it's 3-to-1 in terms of the amount of visitors. But we're the most important tourism destination, and we're the most important cruise ship, the #1 cruise ship destination. That's great for economy because we depend on it. Not so great for disease spread because, of course, this is the way how a lot of our diseases are introduced. COVID-19, especially when the ships go around from all over the world and they kind of hop from one island to another. A ship may be here today in Barbados and then tomorrow it's Antigua, the next day it's in Bahamas. So they're nicely carrying diseases with the people around with them. And the same thing for other types of illness that really propels disease spread. So going to the topic, COVID-19. So because of all of that, when COVID came to the region, it devastated our small islands. In fact, it caused such a big devastation, tourism declined, we had to close borders to protect the region. So the Caribbean is the only region that closed all of the islands at the same time. And we had to do that because we could not withstand Delta. So in June 2020, our first case was in March, but by June we realized this thing was coming. It was going to ravage the small islands. This was virgin populations, and what we had to do in terms of intervention, we had to go to the prime ministers, to the heads of government and say, close the borders for now so that we are able to just withstand Delta. And that's what we did. And really, if you look at our COVID-19 peak, it is not like this. It is more like this because the islands close borders and they take their time and responded. The other thing CARFA did is that we recommended and we did not change from PCR testing. You know, they were using, the world was doing all other types of testing. We said you must have a PCR test, you must quarantine or you must isolate, you must wear your mask and so on. And that went on for a long while. One country, Trinidad and Tobago, was closed for an entire year, depending. So therefore, and that's how we really got on to dealing with COVID. But this slide perhaps is the most important. Because we are a public health agency, we had to take a multi-pronged approach in terms of helping all the islands. The first, we had coordination. Everything, you know, you had to go and talk to your ministers. You had to talk to the chief medical officers. You had to talk to the different bodies. Tourism did not want to hear from us because they want to keep the islands open. They did not understand this could, you know, we had one country says, well, it's in this country. It's not going to go to my country. And I would say it is going to move and go from country to country. So the coordination was important. Speaking with our heads of government and our ministers of health and saying this is serious.
Network with logistic regression. So what is the purpose of these algorithms? Well, for answer this question, we need to understand that we collect all the data from the open source that we can find from COVID-19 in Spain between January 2020 and to March 2022. And with that data, we have a multiple epidemiological variables and use a GDPR compliance. So with all this data, we process the data and put it into the LSTM neural network to extract the future. Extract the future from the analysis of time series. And when we have this extracted future, we implement it into the logistic regression to predict the outbreaks that will come. And then when we finally have all this model, we map it with the spatial analysis to identify where is the regions in Spain that is come or will come the outbreaks. So how we find this all of kind of project? Well, in the first analysis, we can explore in that analysis with all the data that we collect, but the performance with this hybrid model, we have a 94% of sensitivity versus 22 before to applying the small techniques. These small techniques, it makes the balance the data that we have. And then we obtain the specificity to 94.4% that is implied that reduce the false positive or the false outbreaks that we come. And then we have the last metric that is the overall accuracy, like we have 73% that is combine or equilibrate the all metrics before sensitive and specificity. So with these results, we can predict the outbreaks. So in this moment, we have a special analysis and map it into the map, in this case of Spain, the 4 clusters that we can say we can find the prediction of outbreak. The 4 cluster is for the cluster 1 is the critical risk because it needs immediate and intensive vaccination and reinforcements epidemiological surveillance. In the cluster 2,
patient perspectives on stewardship. We asked a question, are you receiving explanation from your doctor in a way that is easy to understand before prescribing an antibiotics? Majority of the patients said yes. You can see that in the cystic fibrosis and OPAT and the renal group were around 90% of they are getting proper explanation. The next question was who is your preferred hospital staff to ask questions on antibiotics? Doctors were by far the preferred choice for the patients, and the next come the nurses. And in some of the groups, like you can see that in cystic fibrosis group, almost equal. Another question was, do you complete the full course of prescribed antibiotics? Encouragingly, the result was very positive, more than 80% in all groups. Like the patient said, they complete the full course of antibiotics. Regarding AMR awareness question, one question was, AMR makes the medical procedures much more dangerous. The majority of the patients were rightly answered. Their answer was the correct answer was marked in green there. I sometimes keep leftover antibiotics at home for a future illness. The patients will disagree with that. That's also in antimicrobial stewardship perspective is very good from the patient's response. If a bacteria are resistant to antibiotics, it can be very difficult to treat. The patients are agreeing with the same statement. Many infections are becoming increasingly resistant to antibiotics. Around 70% say agree with that. I am not at risk of AMR if I take my antibiotics correctly. So 1/3 of the patients said that is a true statement, but that's actually a false statement. So that's a concern there. Again, the next question, AMR is a problem for people who takes antibiotics regularly. Only those who are taking antibiotics, there also the result wasn't expected. That means patient has misconception and poor knowledge in some of the aspect of the antimicrobial resistance. So patient's willingness to ask questions to doctors like antibiotic treatment. So imagine if you are receiving antibiotic in a hospital. Would you be happy to ask the doctor the following question? The first question, what infection am I being treated for? Almost 90% of the patients from almost all the groups say, yes, we are happy to ask, definitely yes, or probably yes was the response. The next question was, how long are these antibiotics being prescribed? Again,
a large private medical center, Bioiatriki, from September 2021 to September 2022. It was for 1 year. And we have used the IGRA methodology, the T-spot for COVID-19, and we have made this estimation of T-cell response, and also the IgG antibody levels were evaluated by the Abbott laboratories. So you can see, I don't know if you can see here the results that we have. Here you see the descriptive data of all the participants in this study. We have examined 262 individuals were included in this study. Among them, we had 82.4% were tested negative, as you can see here. A large proportion of these individuals were tested negative for IgG antibodies, and here I have to say that that was a natural thing to happen, because the people that were tested for T-cell response were those who didn't have a reaction to the vaccination, so they didn't have elevated IgG levels. So at that time they wanted to know if they were protected against the infection, the future infection. So as you can see here, we have 82.4 negative for IgG antibodies, and the others were tested positive, a low level, 17.6. And additionally, we see here that 34.7 exhibited no T-test response from all this cohort, whereas 65.3 had a positive response. We see here that we have an elevated response in T-cell immunity levels. The mean time elapsed post-exposure and vaccination for all participants, as you can see here, was 137.12, plus or minus 78.7 days. And individuals, the results now, the individuals with a positive antibody response demonstrated a statistically significant higher T-spot results compared to those with no detectable antibody levels. Specifically, you can see from the charts here, you can see the first and the second. This one is the quantitative comparison, and this one is the comparison between the positivity rates between the two groups. So the first group is the people with negative IgG antibodies, and the
only to highlight the possibility that maternal vaccine we must administer during pregnancy between 32nd and 36th weeks of gestation, and those I commented already. And the maternal vaccine we administered from September to January for difference of administration of monoclonal antibody, and this is by recommendation of Advisor Committee on Immunization Practice from this year. This is new on. Level of prevention of respiratory syncytial virus infection, we can conclude With these results, it is approximately 80 to 90% related to associated visits for low respiratory tract infection accompanied with respiratory syncytial virus, or hospitalization or admission in intensive care unit. It is in different countries different, but approximately it is ranging from 75 to 85% related to this data. It is just related to healthy term infants, preterm infants, and infants predisposed to severe respiratory syncytial viral infection owing to specific health condition. I wish to highlight that efficiency for nirsevimab is approximately 180 days. For clesrovimab is approximately 150 days. What together suggests its potential, just their potential as a robust preventative intervention for respiratory syncytial virus infection in future. If we talk and thinking about maternal vaccine, with maternal vaccine we reach passive protection immediately via transplantal transfer of neutralized antibodies, and that effect we can keep during first 3 to 6 months of life of infant's life. But different producer, different manufacturer, GlaxoSmithKline and Pfizer has different date regardless that I mentioned talk, but efficiency of RSV vaccines appears to decline, suggesting that periodic booster vaccination may be necessary with maternal vaccine. One of conclusion is that maternal vaccine provides protection immediately after birth, but it has risk for more resistant to potential RSV mutation, and also protection potentially reduced during some period from difference of monoclonal antibody. Protection might last longer, but ensure infants receives antibodies directly rather than rely on transplantation transfer, and from this reason with monoclonal antibody we haven't risk for adverse pregnancy outcomes.
What patient, a 15-year-old girl, is clinically and pathologically identical to poliovirus-associated poliomyelitis with damage to the anterior horn cells, which may progress to respiratory paralysis requiring mechanical ventilation. The classic presentation of encephalitis, which represented the vast majority of our patients, is encephalopathy with focal diffuse neurological symptoms. We observed personality and behavioral changes with altered level of consciousness, neck pain and rigidity, photophobia, lethargy, focal or general seizures, acute confusion or amnesia, flexed paralysis, focal neurological signs like hemiparesis, focal seizures, autonomic dysfunction. We observed extrapyramidal disorders, we observed ataxia, cranial nerve involvement, hydrophobia, which is similar to hydrophobia from rabies, and meningismus, which is less common in our patients than compared to meningitis. Complications observed in our clinical case included convulsive seizures, syndrome of inappropriate antidiuretic hormone secretion, increased intracranial pressure, and comatose state. The objective of this topic is presenting our experience during the outbreak of the epidemic of West Nile virus infection and highlighting the epidemiological, clinical, laboratory, and neuroimaging characteristic of West Nile virus neuroinvasive disease. We managed to collect the epidemiological, clinical, and diagnostic data from a total of 84 patients starting from early July to September in 2024, and the diagnosis was determined by the detection of antibodies in cerebrospinal fluid, detection of antibodies in serum, and sometimes using the last resource, which is urine examination with quantitative real-time PCR. So we already told that our study included 84 patients, and according to the distribution of cases by gender, we evidenced that male cases predominated with 67% and female cases only 33%. According to age, we started, as we said, from 14 years old. I already mentioned the patient, which was 15 years old and which had acute flaccid myelitis. And we went up on 81 years old patients. As you can see in the graphic, these were the age groups and two bands. The age group from 61 to 70 and 71 to 80 dominated the whole chart, with a total of 72.6 cases of all cases. This is my country map, and as you can see, with the red numbers are specified the cities that were the first to show the cases of West Nile virus infection, but which dominated also all the numbers. So we had Lushnia, which led it with 18 cases, and then Fier with 14, Tirana, our capital, with 11, and Berat with 8. These were the cities.
We detect the influenza RSV, adenovirus, and the other respiratory pathogens. What we did, here we did 1 year, from June 1st, 2024 to May 31st this year. That's 1 year, 52 weeks. Then what we see, the February patients, that's about 3,700 for 1 year. Then, and we also check cytokine to see 45 cytokines to see when they face different virus, then what kind of things happen. Here we see 3 waves. First is last summer. This is a COVID-19 we will see. And yeah, this one is the February patients. This one is the 7 pathogens we detected. That's, we see 3 waves. One is in the last summer, and the second wave is from December last year to February. Then the third one is about February to March.
The unvaccinated group, the incident rates, the just HR was 0.1 when compared with the unvaccinated group. So the incremental effectiveness of the one dose as EV was 1 minus HR, and it's 90%. Table 4 shows the incremental effectiveness of EV for varicella incidence rate among students with classroom exposure. Similarly, first dose as EV has lower rates of incidence rates when and the AHR was 0.12 when compared with the unvaccinated group. So the effectiveness of the first dose as EV was about 88%. This study was calculated incidence density per 10,000 percentage and treated emergency vaccination recipient as a time-dependent variable, providing precise rates estimates. The total follow-up reached 53,000%, providing adequate power to detect differences between groups and supporting robust statistics. And we have done multiple models, control for sex, grade level, classroom euphoria, and other confounders to make the results more valuable. And the sensitive analysis minimize the confounding and increase the robustness of our findings. Part 5, limitations. The classroom design cannot exclude unmeasured confounders such as individual immune competence or household exposure intensity, which may influence the results, and the small absolute number in the unvaccinated group limit the precision of baseline risk estimates, potentially affecting the accuracy of incremental effectiveness calculations. Conclusions. These cohorts provide robust evidence that both first dose and second dose emergency vaccination EV significantly reduce incidence during school outbreaks, with incremental effectiveness of 19% and 79% respectively. The findings support immediate emergency vaccination deployment.
Data to understand the biological mechanism underlying the disease and to identify appropriate risk factors. In this context, molecular epidemiology focuses on identifying high-risk individuals and make personalized risk assessment by measuring changes at molecular level, particularly those enabling structured gene damage, gene variations, or the measurement of gene products, including proteins, in cells and body fluids. And finally, environmental risk factors just being listed here. Precision molecular epidemiology describe a process of identifying the genetic basis of disease, including variants within host and pathogens that influence infection, transmission, and now prevention. Molecular epidemiologists, as products of molecular epidemiology, typically focus on determining sources of infection, tracking transmission routes, and identifying genes responsible for virulence and drug resistance to support epidemiological investigations and, more important, reports to the appropriate institutions. Precise pathogen genomes can also be used to inform population-level intervention strategies for infectious disease outbreaks, regardless epidemic or pandemic. In contrast to the design of individual-level treatment strategies in which the functional roles of host and pathogen mutation are critical, outbreak-scale genomic analysis use pathogen mutation as markers of transmissible events. Genomic epidemiology exploits the rapid evolution of pathogens which often accumulate mutations on the same time scale as their epidemiological spread to reconstruct outbreak dynamics from genomic data, thus enabling the design of targeted interventions that are more precise than those based on traditional epidemiological data alone. I mean regular statistics. Examining variation across genomics genomes supports cross-sectional studies for better understanding.
Nigeria, Pakistan, and South Africa, half of the people, half of the TB cases seen in there, but all around the world, we also seen the TB. So it's the world problem for us. WHO aims to limit the TB cases, and 2035 limit the infection of TB in the world. Optimizing the uses of the current tools, the decline has been seen for TB infection, and for the new vaccine and new drug and treatment regime, it has been declined. So we hope. Limitation of BCG vaccine in preventing tuberculosis, it has some reason because Mycobacterium tuberculosis is a very pathogenic bacteria, so the attenuated form of the TB is not, it's impossible. So in the vaccine, Mycobacterium bovis, which is prepared from the bovine mycobacteria, is used for the prevention. So vaccine remains the one vaccine in the world and uses for protection against TB. It's effective for childhood, meningeal and millennial TB, but after that, the duration of prevention for TB vaccine is 10 or 50 years. So after that, latent infection and adult infection is not cured. It has some reason for this, that why BCG vaccine is not sufficient for the prevention. The reason of environmental mycobacteria, non-tuberculous mycobacteria can modulate the BCG-induced production. Differences between
the vaccine dose, and you can measure those using a D analyzer, and you can see when we do that, we get great protection all the way across. So you can see the ultra, so this is our polio vaccine here. So we're trying to make it as good as these guys, but make it more affordable. So you can see it's as good as those there. And then, so there's some more, oh, right, I was looking at the wrong part, wondering what was going on. So we have like another way of looking at extending the availability of doses to people is to use fractions of doses. And you can see all the way here, all the way down to 1/40th of a dose, that we still get protection here. Okay, so this is why we're really excited about it. And it's not a very exciting looking slide, but you can see, so this is, we were looking at how many doses that you would get per batch using this method versus the other methods. So these are made with formalin inactivation versus the UV inactivation with the peptide present. And you can see here in doses per milligram, we get so the lowest one was 250 doses per milligram compared to 14 doses per milligram for the Virapol and 10 doses for IPO. So here is the fold improvement that we get over the other vaccines. So we think that this can be used to extend, so with the same batch, with the same process, by adding this step to it, you could make at least 17 times more polio vaccine. So we've moved into some toxicity studies. So here's our schedule for the immunizations. So we actually did 4 immunizations in this, which is above normal, and then analyze them. So we looked at these metrics here. I think I can go through this fairly quickly because we didn't see anything too exciting or alarming. So all of their body weights were good. so here's more neutralization data. I kind of already showed you similar stuff in the previous slides. And so one thing I will highlight here, which I could have, so we're actually using we're using Sabin strains and a novel oral polio 2 and PV3 Sabin also. So these are safer to handle as well. So they're actually the vaccine strain.